Welcome to this brief lecture introducing the central nervous system as it pertains to advanced pharmacology. Central nervous system drugs are any drugs that work on the brain and the spinal cord, and there are several medical uses for these CNS drugs. It can be used for the relief of pain, to help treat seizures, to suppress those episodes. We also use CNS drugs to produce the effects of anesthesia, and also we can use them to treat psychiatric disorders. However, there have been non medical uses that have been found and often abused. Because CNS drugs have the qualities of stimulants, depressants, it can be used as a euphoriant and other mind altering abilities. These drugs have been used as an abusive chemical. And we still don't have all the knowledge of these agents. We are still very limited because of the neurocomplexity of the brain and the spinal cord. We don't have a full understanding of how these drugs can be used to their full capacity and also how these drugs can affect the whole human body. Remember when we were talking about the peripheral nervous system and we were talking about the three compounds, acetylcholine, norepinephrine, and epinephrine, as being the neurotransmitters? Well, it's a little bit different with the CNS in terms of the complexity. With the CNS, we have at least 21 compounds that serve as neurotransmitters, and you can see them in this box here, box 18.1. There are numerous sites within the CNS, though, that we don't have a transmitter identified yet. So it's still unclear that, whether there's additional compounds that we haven't discovered yet, and also what mediates the central neurotransmission. A lot of information regarding the CNS neurotransmitters have yet to be discovered, and also we have technical difficulties involved in CNS research overall. So there is some uncertainty whether these compounds are really CNS neurotransmitters at all. But even though we don't have proof, we have evidence as we see the reactions of several compounds like dopamine and norepinephrine. So we are more convinced that they are serving as neurotransmitters of the CNS. When we are prescribing drugs, we have to understand this concept of the blood brain barrier, knowing and remembering that the blood brain barrier impedes entry of some drugs into the brain. Because drugs have to cross a specific transport system, but also the passage across the barrier is limited to lipid soluble agents, this can cause a problem for some drugs that we may want to use. Additionally, protein bound drugs that are highly ionized are not going to be able to cross the blood brain barrier. So, what's the significance from a therapeutic perspective or from a prescriber's perspective? Well, the blood brain barrier can be both advantageous, but also it can serve as a disadvantage as well. Because the blood brain barrier protects the brain from injury by potentially other toxic substances, it can also cause an impedance because it will not allow some drugs to pass and provide that therapeutic effect. So it becomes an obstacle. And the blood brain barrier is not fully developed at birth. And so, with this understanding, infants are very much more sensitive to certain CNS drugs than older children and adults are because the blood brain barrier in its infancy and not being fully developed doesn't have the capability of impeding or creating an obstacle for certain therapeutic agents that aren't meant to cross the blood brain barrier. When working with CNS drugs, in order for us to produce a therapeutic effect, there are some limitations and some areas where we have to really exhibit a lot of caution. And this is because, in order to really understand the CNS drugs, we have to understand every biochemical aspect of it and every electrophysical aspect of how the CNS drugs work on the brain. Unfortunately, because of the complexity of our neural system and the brain itself, we don't really fully understand how some of these drugs alter specific symptoms. We also need the full understanding of how some of these disorders that we're trying to treat, will interact with the drug itself, but we don't even have a full understanding of some of these CNS type disease processes. So when we attempt to assign a drug to a patient and to prescribe for a therapeutic effect, we are kind of um, not guessing fully in a way, but we just don't have all the information. So we can't state with certainty how CNS drugs are going to act overall. But there is enough data right now that permits the formulation of some of these drugs because we have plausible hypotheses to support the use. What does this mean? As we continue to study CNS drugs and we are looking at the mechanisms of action, these are still proposed mechanisms of action. So we have to keep in mind that these MOAs or mechanisms of action are really tentative. They are not purely guesses, but they are scientifically informed hunches or hypotheses that allow us to prescribe and use these drugs for therapeutic purposes. And over time, there is a element of adaptation that occurs when there is prolonged drug exposure to CNS drugs. Their effects may differ from those that are produced during the initial use. Over time, we may see some altered effects. And this is because our brain will start to transition and become adaptive to the changes that are occurring when we're using this drug for long term purposes. Our brain's ability to adapt can produce alterations in the therapeutic effects and the side effect profile as well. And some of these things can serve as being beneficial to a patient, although oftentimes they can cause a very detrimental adverse effect. For instance, there are certain drugs used in psychiatry, like our antipsychotics and our antidepressants, that have to be taken for several weeks at a time and even up to 2 or 3 months before a full therapeutic effect can develop. So, this is a way that we are seeing this adaptation as being beneficial. But the beneficial responses are delayed because we have to wait until this collection of effects can occur over time and that these adaptive changes can happen in our brain. Full therapeutic effects are not seen until the CNS has enough time to modify a response to the drug exposure and specifically to a prolonged drug exposure. Let's look at some examples for a decrease in side effects when adaptation of the CNS occurs through prolonged drug exposure. So, when we take drugs for a long time affecting the CNS, the intensity of side effects over time may also decrease. So, the therapeutic effects may go up and be more effective, but also side effect profiles may decline. So, an example would be with the use of phenobarbital, which we use as an anti seizure medication. With phenobarbital, when you take it, an adverse effect would be the sedative effect. And this is usually during the initial phase of therapy. But over time, as the patient's brain gets adapted to the prolonged exposure to phenobarbital, then that sedative effect will start to decline. However, that full protection of seizures is retained, meaning that the sedative side effect decreases, but over time, this exposure to phenobarbital is going to help protect the patient from seizures. So, this is an example of how adaptations within the brain can be a positive effect for the patient. We also need to remember the concepts of tolerance and physical dependence and be able to differentiate between the two. Now, tolerance is when we use a drug for a prolonged amount of time, and over time, we have a decreased response to that drug. Our body, our brain, is now tolerant to that drug. And we're no longer able to either use that drug or that dose to achieve the same desired effect. Where physical dependence is when we abruptly stop a drug, and this abruption is going to precipitate withdrawal symptoms. And within withdrawal syndrome itself, we may see changes in the way our body operates. What would be considered normal brain function while we were on the drug, now we've stopped it abruptly. Our drug adapted brain can no longer function properly. And this is what's causing the withdrawal syndrome to ensue. So, withdrawal reactions will continue until the adaptive changes that have occurred in our brain or in CNS revert back and can be restored to the pre treatment state. As we have talked about psychotherapeutic drugs, we have to also remember that there is constant new development of a new generation of psychotherapeutic drugs. And because we still have deficiencies in knowledge of not only neurochemical reactions and physiological changes that underlie several mental health disease because of the complexity, when we are working with these drugs, we have to realize that we still are relatively ignorant of the neurochemical and physiological correlates of the mental illness itself. We truly don't understand everything quite yet. So, there are two other factors that contribute to this difficulty in generating newer psychotherapeutic agents as well. The first one being that, in contrast to other diseases, we still lack adequate animal models for mental illnesses, right? We may have animal models for diabetes and hypertension or other cardiovascular disease, but we lack these for mental health disorders. Additionally, animal research is not likely going to reveal new types of psychotherapeutic drugs because of this. The second point is that mentally healthy individuals can't be used as research subjects to assess the potential uses for psychotherapeutic agents. So it does take a very long time for new psychotherapeutic drugs to come about, because we're not going to use healthy individuals to try to produce these paradoxical effects. However, it is very helpful to know that after a new drug has been found, variations of that drug can develop. And it goes through a very systematic process. First, those structural analogs are going to be synthesized. They're going to be run through biochemical and physiological screenings to test out whether they have similar activities to that parent compound, or if there are serious toxicities that we need to consider as well. Using this procedure helps us to develop new drugs with fewer side effects. So, even though it sounds like we don't have very much hope for new psychotherapeutic drugs or that they're going to take very long times, we can hopefully continue to study the drugs we have so that we can reduce the side effects overall. So, as we continue to learn this week about CNS drugs, we need to have a certain approach to how we are going to study or examine the CNS drugs. We know that the CNS understanding or knowledge is less complete than what we know about peripheral nervous system drugs. That's going to be the first thing we have to recognize. The next thing is that we have to emphasize the importance of how we understand neurotransmitters and their receptors before we study these drugs, just like the PNS. But because of our knowledge of CNS transmitters being insufficient, while we are examining these drugs, rather than making a detailed examination of CNS neurotransmitters before we study the drugs, we're just going to talk about the drugs and transmitters together.